Good morning to one and all present. We have now reached the final day of the International Faculty Week 2021, hosted by PMS College of Dental Science and Research, and I cordially welcome you all to the proceedings of the fourth day. On the concluding day, we have three brilliant speakers to share their knowledge with us. The first session is by Dr. Clayman, who will be talking to us on surgical volunteerism. At the onset, I wish to welcome our chairman, the moderators for the session, Dr. Suraj Kumar and Dr. Nikhil M. Kurian. Dr. Suraj Kumar completed his BDS from Rajas Indian College, Tamil Nadu in the year 1994 and did his MDS from Rajas Indian College, Chennai in the year 1998. An awardee of FDS RCPS Glasgow, he has also got more than 70 publications to his credit. He is currently the professor and HOD in the Department of Oral and Maxillofacial Surgery, PMS College of Dental Science and Research. Dr. Nikhil M. Kurian completed his BDS in the year 1998 and MDS in the year 2007 from the Rajas Indian College, Tamil Nadu. He has got more than 50 publications to his credit and is now working as a professor in the Department of Oral and Maxillofacial Surgery, PMS College of Dental Science and Research. Now, I hand over the session to Dr. Suraj Kumar and Dr. Nikhil M. Kurian to introduce the speaker and to moderate the session.
Thank you, Gayatri. Being a maxillofacial surgeon, it is really an honor and privilege to introduce the speaker of the day, the Professor Louis Clayman. Professor Louis Clayman, most of you might not be aware of this great person. He graduated, he's got a basic degree of chemistry and a post-graduation in physiology. Later, he went on to pursue his medicine and graduated his dental degree from the Harvard School of Dental Medicine and the medical doctorate from the Drexel University School of Medicine. Professor Louis Clayman has been serving the Bernicia youth community for all their maxillofacial surgery needs for the last 10 or 15 years. And prior to joining the Bernicia oral surgery practice, he was the oral and maxillofacial resident and director at the Sirnia Hospital of Detroit and St. Joseph Callan Hospital for over the 2 decades. Valuing voluntary work, Dr. Clayman has offered his dental knowledge in doing surgeries for cleft lip, cleft palate, facial reconstructions in various countries, like even in India, Nepal, Brazil, Peru, and numerous, Mexico, Colombia, and so on. It goes on. The list goes on. It is really an honor to hear about his perspective of the 30 years experience in volunteerism and surgical practice. So I welcome you to the International PMS International Week of conference. I welcome you, sir, and we all hope to get a good perspective of your 30 years experience in maxillofacial surgery. Thank you.
A dear friend, Dr. Dana York, recently was kind enough to ask me to speak about volunteer surgery around the world at this symposium. I was very happy to comply with her request, particularly since the host institution is located in South India, where in the past I had a wonderful experience in Vellore in Tamil Nadu at the Christian College Medical Center and Hospital. Therefore, or in Tamil Nadu at the Christian College Medical Center and Hospital. Therefore, that gives me a great opportunity to give back a little bit about this wonderful thing about volunteering to do surgery in different parts of the world. I am an oral and maxillofacial surgeon in California, and through the miracle of Zoom, I am pleased to sit at this conference with the organizers and with the participants, hopefully from all around the world, and I hope you will enjoy what I have to say. This is a 30-year perspective on doing surgery around the world. And if I could get this to work correctly, it'll be very simple. I like to divide volunteer surgery into three ways, three different pathways. The first one I'll call the big show, and it was represented by a fairly long-term activity that we had in Ethiopia that was organized by a group called ANAPA, which stands for the Ethiopian North American Health Professional Association. It was organized by a cardiothoracic surgeon at the hospital in Detroit, in which I spent most of my career. The name of the hospital is Sinai Grace Hospital, which is the successor to Sinai Hospital of Detroit. That is a long story about hospitals change names, but if any of you have been following the changes in healthcare around the world, in the city of Detroit, the years 1998 to 2010 were a complete disaster for relatively small and independent hospitals, as a result of which, being one of those, Sinai Hospital of Detroit went through a series of reorganizations and reaffiliations, and ultimately was, I would like to say, almost disappeared into the Detroit Medical Center. And our residency in oral and maxillofacial surgery also underwent several different forms of participation with different sponsors. So back to the subject at hand. At Sinai Hospital of Detroit, now Sinai Grace, a wonderful cardiothoracic surgeon from Ethiopia originally created a group, this group called ANAPA. And his goal was to create the entity of cardiothoracic surgery in Ethiopia, and through his contacts, through classmates and friends and family, he wished to establish an actual new medical school. So this is what I call the big show, or style one, where many different players are involved. Large amounts of money need to be raised. Huge amounts of equipment need to be gathered. Large groups need to be arranged in order to provide the services, both from the point of view of medical care, supportive services, social work, and engagement in the community as well. And none of this would be successful unless the local physicians at the site want this process to go forward, because their participation on the ground is absolutely essential. The disciplines that were involved in this large project were cardiothoracic surgery, oral and maxillofacial surgery, plastic and reconstructive surgery, anesthesiology, nursing, respiratory care, social work, and we had all the Ethiopian families involved in fundraising. So there were three different groups with somewhat different objectives. In cardiothoracic surgery, the attempt was to actually create the entire discipline and start a training program. In oral and maxillofacial surgery, we were working with a local contact who is an amazing man who would be the subject for an entire separate lecture, in which we were dealing with problems restricted to the head and neck. And then there was a small group in plastic and reconstructive surgery who had a slightly different agenda, but was generally involved in taking care of patients with extreme need as well. The second way of having a volunteer activity is through personal contacts. We have a relationship, for instance, with a group of colleagues in another country. and they are requesting our help in order to improve the pre-existing discipline in their country, and while doing so, engage in resident education. And this requires a lot of organization so that everyone is properly credentialed. The people all work together. The patients are selected on the site by both the visiting team and the local team. The cases are evaluated together. The operating room schedules are arranged to accommodate us. We are the visitors, and we are imposing on the other surgeon's time by using the operating room. And sometimes that requires calling in some political favors. And one must do with that which is necessary. I will come back to that when I talk about activities in Nepal. The third way, and maybe the very best, is the long-term one. Let's call this Style 3, or Teaching to Competence. These are long-term projects. The examples are Saving the Children, which is a Michigan-based organization involving restoration of children with clefts, and we have been working in Colombia for over 20 years. The program we had in Vellore, which was organized with the hospital at CMC and also with a group called Health Volunteers Overseas in association with the American Association of Oral and Maxillofacial Surgeons, was a program designed to actually teach the doctors in Vellore how to do complex maxillary reconstructive surgery. This program was stopped after 3 years because they did not feel like they needed us anymore. That was the ultimate success story. We took local individuals with skill and interest, but inadequate training, brought them up to the appropriate level, and then they knew how to go out on their own and no longer needed us. And that was the most wonderful thing. This requires a lot of cooperation between a medical school or a dental school, the nursing staff, the anesthesia staff, and a good deal of organization is required prior to arrival because most of the planning has to be done before the airplane ever touches the ground. As many local supplies have to be gathered as possible. Then we bring in those which are required that are not available on site. We bring in the skill level in terms of attending surgeons with our residents who work one-on-one with the attending surgeons and the local residents as mixed teams in every way imaginable in order to transfer the knowledge the most effective way in the minimum amount of time, because we're always there only for a short time. So the first style, the big one, the big show, as I like to say, took place in Ethiopia and Addis Ababa. And a few years later, we had a little smaller one in Addis, and a few years after that, created a type 2 or style 2 grouping in another city called Gondar, where 2 surgeons from the States and residents met directly with the residents and staff in the hospital in Gondar, and at that time we did a series of head and neck oncologic cases. So about Ethiopia, the resources are limited, as you know, but we have sometimes a special resource. In this case, the Minister of Health was a classmate of our cardiothoracic surgeon, and that, of course, lubricated the wheels quite a bit in order to make things happen. Local funding was aided in the form of supporting all of the visitors. That was 7 surgeons and about 25 additional supportive cast at the Sheraton Hotel, which is a legitimate 4-star hotel. And the person who owned it is a sheikh whose 4th wife was Ethiopian. And when he found out that we were there to do volunteer work for his people, he picked up the tab for all of us, and we all stayed there at no charge, which is very lovely. There was a big publicity publicity push at the very beginning with newspapers present and a lot of press coverage. And this helped to provide a good start in terms of creating enthusiasm within the city for what we were doing, and also making the hospitals, administrators in particular, feel the importance of that which was coming forward, so that we were a little bit more able to enlist their support without too much trouble. We brought a large amount of material with us, and we brought the people required to train post-operative care in the form of respiratory therapy, nurses who could handle the intensive care situation to a higher level than had been previously available. And we had a series of interviews with hospital chairs, the medical school dean, to bring everybody on board, because we knew that there would invariably be glitches along the way, and some way, somehow, we would say something that someone didn't like, and it would be necessary to deal with the political assuagement that is required to make these things happen and not have any hurt feelings. So Ethiopia is a fantastic place, an interesting country in a difficult geographic location in the Horn of Africa. It has a very, very old civilization going back to the time of the Bible and long before, since the Rift Valley runs through Kenya and the northwest corner of Ethiopia. This is also essentially the place where all humankind started. This is a very old place and very proud of their culture. One of the reasons why there is a long history that is well appreciated by all of the people is the religion. They are predominantly Christian. I believe the percentage is about 15% Muslim. And the third minority actually after that were the Jews. And that goes back to the time of Solomon and Sheba. Well, like most of the Muslim world, the Jewish population gradually diminished, and almost all the Jews left during the airlifts to Israel in the 1990s, so that all the falashas, as they're called, were moved to Israel. And one of the people with whom I worked on the second and third trip, an amazing man named Richard Hodes, who's an internist originally from Long Island, who's been in Ethiopia for about 30 years now. He has rescued all kinds of people from the streets with medical problems. He's adopted 6 boys on the street as his own sons in order to have Blue Cross Blue Shield insurance on his policies to get them treated in the United States for TB of the spine. And he's actually been written up in the National Geographic because of many of the incredible things that he's done. So this is the kind of local contact and style, too, that can allow one to have an amazing surgical experience, well organized, without huge resources. The church, as I said, is very important, and they maintain the story of Solomon and Sheba in written form with many variations, and then, of course, the entire structure of the religion around core Christianity in many books going back hundreds, maybe even in some cases almost 1,000 years, can be found in almost any one of the large churches, as you see on the left. And they have another special kind of touristic bent on religion, which is that it is widely displayed that the Ark of the Covenant resides in Ethiopia. And the picture on the right is a place where the Ark would be held. So I leave that one to your imagination. Inside the church, there are these amazing icons all around, as is seen often in most Orthodox churches, in the Byzantine-derived side of the church. And these are quite amazing. And one of these places, I had an opportunity to speak with the priest, and he took out some prayer books and showed them to me. These books were 500 years old, and they were just sitting there. They were not preserved. They were not in a temperature and humidity controlled environment or anything. They were just there to be handled and to be read. Well, I don't read Amharic, so I couldn't read them, but I certainly did look at them with awe because of their antiquity and their importance. Now, when we arrived, the situation changes from the core, relatively calm environment to a big commotion. We came with huge numbers of packages, as you see on the left, cartons of equipment, and on the right there was like a large reception area with the newspapers, and this was a very big activity. We made a major news flash on arrival. The group was introduced to the public and to the press. You could see in the upper level on the left, that was the chairman of one of the hospital departments who was looking on. And that's Dr. Inge de Asfa on the right, who's the cardiothoracic surgeon who organized this, who is a dear man, a wonderful guy with a wonderful heart, who has been committed to improving life for the people in Ethiopia during his entire life. And now that he's reached the level of being a senior cardiothoracic surgeon, he finally had the means to give back with much more than just money. After all of this interesting touring information and meeting the political people, it's finally time to get to work. And this took about almost 3 days to get everything organized and arranged. Now finally we get to the clinic at St. Paul's Hospital, and we wound up having activities in 4 different hospitals: the military hospital, St. Paul's, a couple of other hospitals that were small hospitals. But the oral and maxillofacial surgery group worked at St. Paul's Hospital. And this is typical of most of what one sees when working in the third world. On the right is the actual emergency room or catchment area where people will come in from outside to be seen. They're seen one at a time because there's not very many rooms for them to be seen, and they rapidly fill up the rooms. And as soon as the rooms are filled up, the outflow is outside. So one can see large numbers of patients in the hospital, outside the hospital, on the street before you get into the hospital. And the word flies like fire spreading when the word is out that there are people who have just arrived who want to do things to help the local folks. And usually the people will know what the disciplines are. So if it's oral and maxillofacial surgery, all of a sudden people with clefts will come from all over the place, people with gunshot wounds, facial deformities, head and neck tumors will suddenly appear. The grapevine works amazingly well without any type of electronic communication. It is incredible. So the first day is screening time, and we'll see all different kinds of patients, but we're only going to be there for a week or 2, and at the most we could do 3, 4, maybe 5 patients a day in the operating room. Usually 5 is a bit of a stretch, and we try to limit the procedures to an hour and a half per patient because the turnover is slow, the demand is high, and the resources are extremely limited. And we can't do everything for everyone. And sometimes it's really difficult to say no. So here are 2 little children. The one on the screen on the left has a hemangioma of the cheek, which has been interfering with feeding. And this poor little guy on the right-hand side has what's probably a large cystic hygroma on the back of the neck, a big tumor filled with lymphoid tissue, or perhaps something else. We don't really know. All we know is that we're not equipped to do pediatric surgery except for the clefts that were part of the program, and we had to say no to these children. Then we find extraordinary things that would require additional therapy but would be impossible to treat in a limited time schedule. Here's the lady on your left-hand side of the screen. She looks fairly okay, except that right over here, there's a little indentation in her cheek where the skin is starting to break down over this mandibular reconstruction. This mandible was reconstructed with a coat hanger that was sterilized. The top part of it was bent to form a temporomandibular joint in the form of the condyle. Here's the ramus and the body of the mandible, the symphysis. And this is an amazingly fine job of symmetrical wire bending. This is really amazing. And this has been in there for about 2 years. She originally had her entire jaw removed because of a huge ameloblastoma that occupied the entire mandible except for the ramus. That at least is what I was told. And now she would like to have a real jaw. But to restore a mandible like this requires a gigantic hip graft, or better yet, a free fibular vascular graft. And we did not have the ability to do that. That would require a team to harvest, the team to reconstruct, and then the microsurgical reapproximation of the blood vessels. And under the very best of hands and ideal circumstances where people do this 2 or 3 times a week, an operation like that would take at least 6 to 8 hours. And this would basically be an all-day, a literally all-day case. And we couldn't do that because if we were to do her, there were 4 or 5 people who could not be treated. So this will have to wait for another time, or perhaps a benefactor will arise who will allow her to be transported to another country for treatment, as had been done for quite a few patients by Dr. Rick Hodes, as I had mentioned before. The war with Eritrea just finished a few months ago, but went on for a decade. And now it heated up again in the border zone in the northwest of Ethiopia. And as a result, there are so many patients around who have been shot in the war and never reconstructed because all they could have was emergency, temporary care, basically first aid. There are no MASH hospitals in Ethiopia. There are no secondary hospitals to which a patient can be transported by helicopter for definitive surgery a few days after stabilizing the patient and dealing with the early phases of wound treatment. It just doesn't exist. So we see people who have been badly injured and need to have a great deal of work done. And sometimes we can take care of them and sometimes we can't. And this is one of the great frustrations of volunteer surgery. You are presented with so many opportunities to do all kinds of wonderful things, but the time is limited and the support services are also unfortunately limited. Then we have patients that we've never seen before that we don't know quite what to do with. This is a lady with this heavily pigmented lesion of the entire left side of her face around her eye. I've never seen this before. I've only read about it. It's probably a nevus of Ito. Ito is around the eye. There's another one called the nevus of Otto, which goes around the ear. And this is the sort of thing that really could only be treated by laser to try to reduce the density of the pigmentation by eliminating some of the melanin so the skin would look a little less abnormal. But it's really not amenable to surgical therapy. So after we see all these patients, we triage the cases, try to arrange them so that we can do it in the most efficient way, minimizing the impact on the operating theaters, and do as much workup as possible so we know as much about the patient as we can in advance. There are CT scans available sometimes. The CT scanner is occasionally available. Pathology was another story. It was almost impossible to get any type of pathologic report back quickly, and the reliability of the diagnosis was usually highly questionable. And then this all had to be arranged with regard to the anesthesia coverage. Aside from the anesthesiologists that we brought with us, how about the local guys or girls? Are they comfortable doing anesthesia and airway management for the types of cases that we were doing? These are all questions that had to be adjudicated prior to actually scheduling the patients. So now we think about these cases and we organize them. And I'll tell you, it can give you quite a headache and make you feel really bad to know that there are so many people who deserve to be helped but you just cannot help everyone. And triage is very tough. And afterwards, it makes you think quite a bit about what we're actually doing and how much can we do. And we try to do as much as we can within the means that are available and be satisfied with that. And a reminder of the type of place in which we are working are these two slides. The top slide shows a whole herd of goats right on the main street on Haile Selassie Boulevard in downtown Addis Ababa. Right next to it in the upper right-hand corner are some cars. The city, at least at that time, and this is only about 10 years ago, was replete with 40-year-old Toyotas. That seemed to be the car most suitable for taxi use. And I was in several taxis that were quite remarkable that they were still on the road and certainly would never have passed California state inspection. One of the most memorable ones was with a driver who had the window open and his arm outside the door. That's how he kept the door from flying open, because it didn't close. And the steering wheel, to make a left-hand turn, you had to turn the steering wheel about 5 complete rotations before the car started turning. Fortunately, nobody went more than about 25 miles an hour, so most of the accidents were no consequence. On the lower side, on the left-hand side, is the entry to the Mercato. And the Mercato is the largest market in the Horn of Africa. It is huge. I don't know exactly the size, but it takes about 20 minutes just to walk across it. And there's everything there that you could possibly imagine. And to go off on a slightly different subject, it's quite remarkable what is being sold. The USAID activity is very large in Ethiopia. And at a cocktail party at the embassy one time, I was speaking with one of the workers from USAID, and I asked her about the budget. And basically, the budget reserves 30 to 40% to cover pilferage and bribery. And as one goes through stores, especially in the rural area, even more than in the city, little tiny shops selling some fabrics or batteries or anything you could imagine, there are almost always the top 3 shelves in this little place stocked with about 40 or 50 one-gallon cans of oil, cooking oil, that say on it, USAID, not for sale. And that's a problem, because try as we might with providing funds for underdeveloped countries with lots of aid, we know that a lot of it is just going to be stolen and disappear, but it still gets to people who need it, so I suppose in a way it's okay. The opposite of that is where we stayed at the Sheraton Hotel. I told you just a moment ago about the sheikh who was kind enough to allow us to stay there at no cost, which was lovely. It's a lovely place, and it provided a really nice oasis in the middle of a very hectic city after a very stressful day's work, where we had to deal with patients, associated individuals, families, the cleaning staff at the hospital, all kinds of things that just made it very frustrating. So it was good to have a nice place to relax. We were very lucky about that. As we wandered through the Mercato, as you see on the left, you have to think about the kind of living that goes on in places like Addis. The people living on the street, the kids on the street, or the young adults with no jobs and no education. Here was a young guy, the one in the middle. He had a shoe shine box. I got my shoe shined for like 35 cents or something. And he had a can of Esquire shoe polish, black shoe polish. And he would just barely touch the polish with the tip of a cloth to shine 2 shoes and, finished up the job so that he would make this thing last as long as possible. But that was money. And that allowed him to make a living. And from one shoe shine box, you can get to two and then have somebody else work for you. And this is like the entry position where people with no other means of supporting themselves can finally start to feel like they're doing something constructive and they can take care of themselves and ultimately of their family. You have no idea how such a seemingly trivial job like shining shoes can give someone a sense of self-respect and worth. Incredibly valuable. On the right-hand side, we have a mosque, and some of the mosques are on buildings that used to be churches, and they seem to be coexisting nicely, at least so far, and hopefully there won't be any religious conflict in this country for a long, long time, and hopefully forever, that there'll be none. Now we have to get to work. We've had a little tour of the city. We've looked at the different kinds of patients. We've lined up our colleagues, tried to make teams of surgeons and residents, visiting and local, and now we're going to actually go to work. So we've selected the cases, and one of the cases was this young man whose nose was distorted, his eye has been disturbed, and he can't breathe through his nose because it's really stuffy. And we have no idea what this is because there was no imaging and no biopsy. One of the local surgeons, who was actually from Cuba, and the Cubans pay their surgeons to go around the world and spread the word of communism. So his choice of place to go was Ethiopia. And he became a very good friend in the time we were there. And I said, hey, Felipe, how about tissue diagnosis? He says, don't waste your time. We do tissue diagnosis, we get an answer. We take the tumor out, we get another answer. Every time we send a piece of tissue, we get a different answer. So we really don't know most of the time what we're actually operating on. Unless, if it's malignant, sometimes we can tell for sure that it's malignant. But most of the time, the pathology is very slow. It takes like a month to get an answer back, and it's usually unreliable. I said, okay, so here's a fellow who can't breathe. He has his one chance to get this tumor removed because this is going to require a large operation, and the people on site are not maxillofacial surgeons. It's probably not within their comfort zone to do. So we're just going to go ahead and do them. So we did. So this is a open face maxillectomy, a Weber-Ferguson approach on the right side, where we do what's called a face splitting incision. The incision comes from medial to the medial canthus, round under the nose, splits the lip. And now once this is done, you can reflect the tissue so that this part, which is this side of the flap, is over here. And this part here, which is the side coming up over his nose, that's the nose is part of it. This part is moved over. And we remove this tumor. This is the root of the apex of the root of the right maxillary canine. And here's a large defect, which we created, going into his nose and sinus. So it's basically a maxillectomy sparing the alveolar segment, because this is really a nasomaxillary tumor. It really doesn't involve the tooth-bearing part of the maxilla. So this was all removed. We packed it, closed him up, and this is what he looked like 6 days after surgery. Making rounds on him the day after surgery, after a maxillectomy and partial rhinectomy, I asked him the following morning, well, how are you feeling? And he puts his finger on his nose over here. He taps his nose with his finger, and he goes, pretty good. Thank you, doctor. Little pain in nose. That was all he said. And what he had taken for pain medication post-operatively were 2 ibuprofen the night after surgery and 2 in the morning. That was it. And he was very happy. And we do not know ultimately what the result was of the pathology because there was no pathology. On a different subject, we had this war with Eritrea going on, and a patient several years ago had a blast injury to the right side of his face and the left side of his head. And as you can see, he has a saddle nose deformity because The nasal bones are missing. Septum's been destroyed as well, probably. His orbit is sunken in, so he's anophthalmic, although his eye actually was functioning. He still had vision in this eye. And the orbit was comminuted. And we did have some plain film x-rays on this person, so it was not a mystery. It's clinically what was going on, and the x-rays were somewhat helpful. So after a long discussion between the visitors and the on-site people, we decided that since this is a very upstanding guy who wanted to go back to life and work, and he had a job even, had a family to take care of, could we make an exception and do a long case on this person? Because if we could take 4 or 5 hours to rebuild him, that means there are 2 or 3 other people that aren't going to have surgery. So we had a long discussion about that. And finally, they decided, they pushed us to do it. I think maybe somebody in the hospital knew his family or something like that. In any event, we agreed. So I'll show you how we got from the pre-op to the post-op here. Did a bitemporal flap. So here's the incision on across the top of the head, and we have the usual sutures to keep it from bleeding. And we bring this down in a subgaleal plane and pull down the entire forehead from the top of the scalp down to the eye, down to the brow level. So the supraorbital ridges are here, the top of his head is here, and his bones are here, and they're healed, but they're a little in and out, they're displaced. His nose is completely flat, and on the right side, he's missing a significant amount of bone. So we need to get bone from somewhere. Well, the iliac crest is the best place. So at the same time as doing the flap up above, the bitemporal flap, the second team of oral and maxillofacial surgeons exposed the hip on his right-hand side, and we took out a piece of his hip, a bicortical piece of hip. So here's the cortex, and the medullary bone. And now we have to shape this bone into a little bit of a curve to replace the orbital floor, and another piece going out this way to repair the zygomatico-frontal area. And what are we going to do this with? Well, there are no reciprocating saws. There are no oscillating saws. I guess they do orthopedics, but the orthopedists maybe would not let us have the saws. But in any event, we had no saw. All we had was a drill, and we had a set of osteotomes and a mallet. So we went about marking this out with a mallet and osteotome, and we did it. We created the pieces by carving them out with those instruments. And then we did have some screws, so we were able to screw the bones in place to replace the side of the orbit. I don't have the picture of the orbital floor, but we did that as well. Dissected out the soft tissue, propped up the eye so his anophthalmia was created and brought his eye forward. And then through a little slit incision over the nose, we did a blunt dissection to try to put another straight graft here to replace the missing dorsal part of his nose. And that's what we did. So this is him about 7 days later, just before we're getting ready to leave. We had put a little bit of bone up in here where this dip was over here. We added some bone here. Where he was somewhat flat up in this area, we added the bone on the side, propped up the infraorbital area, and a nasal strut. So that was a long day, but a very satisfying case. Then we find the typical African tumor. I've seen this in Ethiopia. I've seen it in Nepal. It's just absolutely amazing. In rural Africa, in rural Asia, in rural South America, we saw something like this in Peru and in Colombia. People just don't get treated. And what happens is, since they have no allopathic medical care available, they go to the care that is available to them. And those are the local healers, the faith healers. We used to call them witch doctors. Wrong term. That's a pejorative term. There's people trying to do the best they can. They just don't have a way of doing it to the standard that we know works. And of course, the real problem with local therapy, is based upon herbs and incantations and lots of surgical incisions to let out evil humors. All that does is delay things. So the tumor continues to grow and grow and grow. So that's why many of these patients, you'll see lots of scars in the skin over the tumor, like through here. This is from the tumor, but this is from an incision. That's her eye up there. So here's this gigantic tumor. And this one, during the triage time, went to the plastic and reconstructive group. So here's the one x-ray that we had is a CT scan, not too bad. Giant mass occupying the orbit going and the maxilla. So she came to the operating room, and I don't know how to go back here. Here we go. And the tumor was excised. The skin could not be saved because it was infiltrated by tumor. So there was a large open area here that required some flaps from the neck to be mobilized in order to get a primary closure. So this was rotated forward and closed, and this is her about 5 days afterwards. And the eye was preserved. It was under the eye. It didn't involve the eye. It was under the eye. Now, what's very common in every place I've been is ankylosis of the temporomandibular joint. Antibiotics are not widely available in rural communities. Kids get infected ears there, just like they do here. Here we treat everybody with penicillin. There they don't get treated. So if you have an otitis media that gets out of control and it goes beyond the boundaries of the middle ear, the next place medially where it'll go is to the temporomandibular joint. And now you'll have a septic arthritis involving the joint. Well, once that happens, when that finally heals, the proliferative healing response often results in the deposition of bone, and a bony ankylosis develops. And if it happens during the growing period, as you see in this man on the left, this probably happened when he was 6 or 7 years old, maybe even earlier. It looks like he has no mandible. His lip is protruding downwards, he has no chin, and he really can't open. He could open about 2 or 3 millimeters. And that was how much the mandible will flex if you press hard between the upper teeth and the lower teeth. That's how much the bone itself will flex. There's no movement at the joint at all. Now, these are scary cases because you have an airway problem. You can't open the person's mouth. Any access to the airway has to be either through a nasal intubation or through a tracheostomy. And nasal intubation, awake nasal, is fine. We do that all the time here. And with the advent of bronchoscopes that you can see through, namely endoscopic procedures, you can do it fairly nicely without spending a lot of time. Whereas in the old days, a blind awake nasal could be a formidable intubation procedure. So in this particular case, we trached him under local anesthesia first, then did the operation, which was to remove the block of bone and finally get his mouth open. And this is him actually in the recovery room, maybe the next morning, something like that. But for these things to really work, they have to have postoperative physical therapy. And there's no such thing as a physical therapist that does this kind of work there. So we teach the patient and the family what to do and hope that they will continue to do it. Because if they don't mobilize the jaw, he has a fairly good chance of getting a partial re-ankylosis. The most common thing that we probably see, or the one that gets people's attention the most because it grabs you at your heart the most, are the little kids with clefts. Now here's a right incomplete cleft lip. The characteristics are that there's a closure of skin and mucosa at the upper aspect of the cleft. The lesser segment, that's the one on the cleft side, is always deviated to one side. The alar base is similarly deviated, so the nostril is horizontally oriented instead of vertically oriented like it is on the normal side. And this one has a cleft in the alveolus as well, although it's a tiny one. So I use the Millard rotation advancement technique to close it, in which you make an incision up through here and around up through here, and we transpose these tissues. We make an incision at the junction between the skin and the mucosa, here and here. Reflect the mucosa, dissect out the muscle, so the orbicularis oris muscle is freed from both ends and reapproximated. So there's now a creation of a proper muscle band that goes across this and recreates the plumpness that should be felt in the lip at this area. So it should be correct thickness all the way around. And then we rotate the segment. This segment comes down, and this comes across like so. And this is the child at the time of suture removal 4 days later. He has a nice Cupid's bow. It's symmetrical. You can see that there's an equal mass of tissue here and here. That's the orbicularis oris reconstruction. And by bringing the alar base in, that tends to push this part of the nostril up, and it changes the orientation to more vertical instead of horizontal. It still doesn't match completely, but it's a lot better than it was. And that takes an hour. It takes an hour and a half to do, because it takes a half an hour to put the patient to sleep, about an hour to do the surgery, and then you have to wake up the child, bring him to the recovery room. So it basically ties up the operating room for about an hour and a half to 2 hours, which is a very good use of time, because you could completely change a child's life like this. On this particular trip, my wife was with me, and there was a child a little bit more severe than this, and my wife's name is Minu, and Minu was talking to the mom after this child with a complete unilateral cleft was repaired. So when complete cleft, it goes all the way up into the nose, and it looks pretty bad. And the woman was crying and saying to Minu, "I thank you so much. Today you've given my baby her first birthday. Like her life started from today." And that was very, very powerful. And it's comments like that which is why I do this. Here's a man, unrepaired, unilateral cleft lip, and a wide open palate. So he talks like this because he has velopharyngeal incontinence. He can't block the flow of air through his palate, so it goes out through his nose. So he has a really hard time communicating. And people will make all kinds of assumptions about his intellectual capabilities because he talks funny. There's nothing wrong with his mental abilities, he just can't speak properly. And of course, the total number of speech pathologists in Ethiopia when I was there the first time was 1. So, there's more work than any one person can do. So this was a single-stage repair, which came out nicely, and afterwards the speech was vastly improved. And just by practicing speaking with a repaired palate, he could make himself understood quite well. This is his lip repair. This is the rotation advancement I was telling you about. This is the non-cleft side, where we come in here and let this drop down, and then free up the cleft side and bring it straight across, sew it up together. Here's an adult in his late 20s with a bilateral cleft lip and palate. This is different. This is you can never make this great in one stage. You always have to do additional things to make a bilateral cleft lip come out really nice. It's a much more severe deformity than the unilateral case. And this is the repair of the lip. And this is a classic Vaud type repair where we have 2 flaps from the palate. They bring them together. I bring them together and repair it in 2 layers. And this is him a few days later. So he went from being socially anathema and rejected by society to somebody who just looked a little different from everybody else and could function all right. Here's a bilateral case in a youngster, same thing. That's my wife. providing nursing care, getting a 1-minute break between cases. And then we have the occasional horror that can't be fixed unless you have special abilities like microvascular surgery. This is a Noma. This fellow started out with a tooth infection and he lost his entire maxilla, his lip, and part of his eyelid. So there's another name for it is a cancrum oris. It's a mixed anaerobic infection closely related to acute necrotizing ulcerative gingivitis, and it occurs in people who are severely immunosuppressed. And seemingly, episodes of Noma occur during measles outbreaks in parts of the world where malnutrition is rampant. Now here's something that one is unlikely to encounter anywhere except in Africa, actually. It's a hyena bite. This poor kid was a street kid, and she was out foraging in the garbage dumps for food, which put her in competition with a hyena who was foraging in the same place. And this hyena bit her and actually bit off her lip, the skin, and her mandible. And this requires a gigantic reconstruction that hopefully someday she will have. At the end of the week, get a chance to relax a little bit, tour the countryside. Here's what one of the rural churches look like. And here's a typical view of East Africa up near the Rift Valley. You know, the classic food of Ethiopia is injera. And injera is cooked in these special pots. And here's a place where you can buy injera pots. But if you want to get anywhere, basically you walk. And here's protection against the cold and the cold winds and the bad weather. When it rains, you need to be kept warm. No shoes, of course. Here's a shepherd with his cattle, covering many, many, many miles. And here's the most curious thing I saw the whole time I was there. I'm a cyclist. This is a drive-in bicycle wash. So for some amount of money, you can bring in your bicycle, and these two guys will clean it up, clean the chain, wash it down. I don't know who has oil to oil the chain, though. And everything comes to the market on foot, not by truck. And the last thing we did was go out to Bahar Dar in the countryside. This dam, well, sorry, not dam, this river is the Blue Nile. This is the origin of the Blue Nile that goes northwards and merges with the White Nile to form the Nile. I don't remember exactly where in Sudan that happens, and continues on through Egypt to drain into the sea at Alexandria. Well, second type, personal contacts with institutional support. I will talk a little bit in this one about Nepal. So Nepal was created, this is the first time I went in 1988, the first trip I did. I went to Nepal for 3 months. And I had the volunteer staff at the hospital cover me. I was the department chairman, and obviously I needed people to run the place while I was gone, and they were kind enough to cover the clinic so that we could continue to function, you know, without my leadership. And we brought residents with us, worked with residents and local dentists at teaching hospital in Nepal. And one of the amazing things is my best friend in Nepal I met that time, Basanta Shrestha, was a young surgeon, a young general dentist, and he spent the 3 months with us. When I went trekking with him, became good buddies. He wanted to become an orthodontist, and he did. He went to India, became an orthodontist, and years later he established the first orthodontic residency in Nepal at teaching hospital, it's Tribhuvan University Teaching Hospital in Kathmandu, and created the Journal of Orthodontics of Nepal. So he's done some amazing things. I like to think that maybe our time together stimulated him to do some of this. So we tried to go in groups of 2, sometimes even 4 attendings. We had up to 5 residents, all the local contacts, and anybody who was interested could come to work with us, any of the dentists. And there were no limits. Whoever wanted to come in could work. And why Nepal? They have the need. I have a need to go to places like Nepal because I love mountains. This is Mount Everest from an airplane. It's a place with many different cultures, and they seem to actually coexist very beautifully together. These are the great religious shrines at Bodhnath and Swambhunath, and the Buddhists, who are the minority, and the Hindus, who are the majority. They do coincide. They do coexist very well. They live together quite peacefully. And you'll find all kinds of interesting things in the same places. Here's a statue of Ganesh, who's one of the idols, and he's sort of the one you pray to if you want good fortune. And here's a professional sadhu. He said, here I am, look how good I am. Take my picture, but give me 10 rupees. So he made a career out of posing, which was fine. He had a chance to make a living, and I had a chance to have a really nice photograph of an interesting person. Nepal is landlocked, as you know. The only lake in the entire country is called Lake Phua. This is in Pokhara. And this is a famous mountain called Machu Picchu, or Fishray Mountain in Machu Picchu. And it's where the Annapurna Sanctuary trek begins. Kathmandu downtown is a very cosmopolitan area with these fantastic shrines and stupas. It's an amazing place. Many of these were destroyed in the earthquake a few years ago, and most of them have been rebuilt, but it was terrible that that happened. And one should know that even more than in Ethiopia, the only way to get around is on foot. Even today, very limited road services, but an excellent pathway of footpaths, and the footpaths go everywhere. And here's the footpath at its widest, where it's going through a village. People will sell whatever they can on the street. You know, there's no licensing. These things are called chataras. They're little rocks on the trail where they're built up about thigh high, so you could sit on them and rest your load that you're carrying. I was carrying a backpack, but one of the porters was carrying a sack attached to a thing that goes around the head, a band called a tump line, and they would carry, a 55-kilogram guy would carry 50 kilograms on his head up and down. Here's a young girl with maybe her little brother was hiking, walking. She didn't do it to hike. She's walking from, to the village to buy food, to the store and that sort of thing. She stubbed her toe and cut her toe, so we stopped to put a Band-Aid on, and we had a lot of giggles over that. Now we get to work. And we start with examining what's going on the street. Just having us brings people around the clinics, as you saw in the very first slide on Ethiopia. Here's a guy, between his deformed hands, he had like a business card that said, please, I'm a beggar, please give me some money. And I said, well, why don't you come to the clinic? And I took one of the cards and I told them where to come, so maybe we could help you out, at least with your teeth and with your nose. Your nose is gone. And this is a person with end-stage leprosy, not something you see every day. This poor guy was attacked by a Himalayan blue bear that ripped out his eye on this side, took out his nose, his zygoma, part of his frontal sinus. A few teams had been in Nepal before us. I was the second team, but there were some plastic teams that were there a few years before. Somebody raised the flap from the neck, and they had to go home. They couldn't do anything with it, so it was just hanging there. And he needed more treatment too. Outside a hospital, in the Shir Memorial Hospital in the surrounding or nearby town called Banipa, they heard we were coming. This fellow took his kid out, found out that we were coming, and the neighborhood kids popped up. Look at me, I have a problem. Can you do anything to help me? There's no shortage of patients. When we got to Nepal, to Kathmandu itself, we found the toothache god. This is a idol, the toothache god in the street. This is my good buddy Al Steins, who's a prosthodontist that I brought with us on our first trip, and there's actually a dental clinic at the teaching hospital. They had academic capabilities with classrooms. We had some nursing staff, recovery room, and a real operating room with pretty good anesthesia equipment. This is my chief resident. This is an anesthesiologist from the University of Michigan. Here's the local guys getting ready to induce this young child and for anesthesia. And post-operatively, we had a recovery room. Unfortunately, the recovery room doesn't have any nurses in it. That's a problem. That means an ankylosis case or anything involving the airway could mean trouble because patients can't be watched as carefully as you want them to. Again, we have the tumor problem. Here's a lady with a giant tumor. It's actually starting to come through the skin. We don't know what it is, can't find out what it is. So we took it out, closed it. I took a piece of this as well as some other tumors, provided small biopsy bottles with formalin in them, labeled each one, put it in my luggage when I came home, snuck it past customs, and I had the laboratory at Sinai Hospital diagnose it, all these different patients. Even did one with water. We brought it to the public health department to see if there was any fluoride in the water. And this lady had an osteosarcoma. Unfortunately, no adjuvant therapy was available. She had a clear margin, actually, and maybe she did okay, but we'll never know, which is another problem with volunteer surgery. Unless it's recurring, you don't know what happens. The guy we refer to as Bear Man, here's the one who was attacked by the bear. We're going to start doing what we can to make him look more presentable. So we're going to put an obturator in his eye socket to maintain the volume of the eye socket. And these are marbles. These are marbles like kids play with. We sterilized a group of marbles and chose whatever one would fit the orbit the right way to help maintain the orbital side. And we skin grafted in order to create a receptacle for a proper ocular prosthesis at some later time. And we also, remember that flap that was around here? We took this flap and put it back because we didn't need it. And on another trip, we'll start working on what else has to be fixed. Here's the kid with the bilateral cleft lip and palate. This is the repair. And here he is about a week later, a little after the stitches came out. So, you obviously could see that he still has a problem, but he looks a lot more presentable than he did here. And that was great because that makes him deal with life more easily. Here's a young girl who's the same way. Here she is in 1988. And they knew I was coming back in 1995. So the family sent me a photograph of what she looked like 7 years later. And this is her 7 years after her lip repair. So I was pretty happy with that, as were they. Here's another ankylosis case with removing the block of bone that's keeping the jaw from moving. And here's the same kid 8 years afterwards. He's still asymmetrical, but at least he's opening his mouth, which is not bad. There's another hospital we worked in called the Bir Hospital, B-I-R, and this hospital was built in the 1960s. I was there in 1988, and this hospital inside, this is inside, it looked like maybe this was built in the 15th century or something. It was so dim and dark and poorly staffed. It was just so sad to see these people. And they're just sitting there waiting. All they can do is wait, hope that somebody will have time to eventually look at them and see if they could help them. And with us coming in, at least we could move the line a little faster because we had more people to put eyes on the patients and make some diagnoses and triage them. Well, being an optimist, I had a lot of contacts with a group called the Nepal Oral Health Society, and they were trying to improve oral health in Nepal. They organized a yearly oral health day, which later on became every 6 months, where they go out into the provinces and do mass screenings, looking for oral pathology and trying to get, especially the kids, some kind of dental care. But they had no real facility. Well, when I lived in West Virginia, when I first started my career, my next door neighbor was a young kid. At that time, he was about 15, and he wanted to be an architect. And he became one, and we had contact with them from time to time. So 15 years later, he's a successful architect in St. Louis. And I said, Brian, can you do me a favor? We want to build a health clinic. And I gave him the dimensions and how much land we had. Could you draw up some plans? And he did. So free of charge, which is incredibly nice, he drew actual architectural plans to build a 2-story maxillofacial clinic probably on this site, because one of the guys in Nepal Oral Health had access to buying this land. Well, it was a great idea, but it never came to pass. Another frustration. Within the group, there was enough political dissension among this group of 12 people that were the Nepal Oral Health Society that they couldn't see eye to eye about what to do, and then somebody got angry, I think, and left, and that was the end of the project. However, some projects did go forward. Namche Bazaar is an area in the Solukhumbu area where external organizations plus local funding were able to create a health clinic. It is an oral health center right there in Namche Bazaar, and they will treat everybody in the Khumbu area. A tooth extraction costs the equivalent of, I think, 50 cents. And if you're a foreigner, and this is in 1998, I think, and if you were a foreigner and you came in with a toothache, it would cost you $25. But they could take care of the local people, which is wonderful. And it's right next to the famous monastery at Sangboche, which is maybe not as famous as the one at Tangboche, but still it's amazing. These monasteries are remarkable places. Don't have time to talk about them, though. This is the Imjakola, which is a river running in northern Nepal, and near the Sangboche Monastery, the beautiful area where the yaks love to munch on the grass, and these are yaks. And yaks carry all the heavy goods throughout the high mountain areas of Nepal. In Solukhumbu, you can fly into Namche Bazaar or into a place called Lukla. Now, this is the landing strip at Lukla. That's the whole strip. You see here, there's an edge. There's a fall off. It's a valley. It goes boom, right down. And the way to get in and out of here is on one of these Sikorsky helicopters, which are horizontal takeoffs, and they go horizontally over the edge, because they only need about 100 feet or so to take off, and then you're airborne. And when you come in, you're coming in, and right in front of you is the side of a mountain, and it looks like you're going to crash into the mountain. And then you just go over the lip, and boom, you're right on the landing strip. It's a pretty exciting ride in the airplane. So here's my buddy Basanta. This guy, Frank Kelly, when I was in West Virginia, in Huntington, West Virginia, at Marshall University, Frank Kelly came to me one day and said, "I'd like to learn how to take out teeth and do jaw fractures." I said, "Wow, why do you want to do that? You're doing family medicine." He said, "Yeah, but I want to be a missionary, and I need to know how to do this stuff." So I taught him. He spent 6 weeks on rotation, and that was in 1980. And in 1988, 8 years later, at Banipa Memorial Hospital, Banipa, that's Sheer Memorial Hospital in Banipa, I'm operating one day, and one of my colleagues, Bruce McIntosh, says to me, "There's a guy here named Kelly. I think he knows you." And sure enough, it was Frank. I said, "My goodness, I'm really glad to see you." I said, "What are you doing?" He said, "Oh, I run the hospital. I'm the head of medicine here." I said, "Really? Do you run surgery also?" She said, "Yeah." "Can you control operating room times?" I said, "Yeah, okay. I want Tuesday and Thursday at 7 o'clock. And I got operating time at Banipa because of Frank Kelly. It was amazing. Those are the personal connections that make things happen. Now we come to Vellore in South India. One of the most amazing places. You know it better than me since you're located here in Tamil Nadu. We came there to teach orthodontic surgery, which is difficult, to general dentists, and ultimately they were able to do it and didn't need us anymore. The Christian Medical CMC hospital in Vellore has like 45 buildings. I still get their yearly budget every year, their yearly report. They have about $14 million that they raise every year to take care of things. They're building, they do neurosurgery, cardiothoracic surgery, oral maxillofacial surgery, neurology, every discipline you can think of. It is a first-class place, absolutely amazing. And we were there in the 90s before they became quite nice in terms of physical structure. But they already had the plan in mind. They're building, they're organizing. They have closed circuit television to use so we could do demonstration cases, because you can't fit all these people in the OR at one time. but you could have them watching as we're doing it by having a monitor and having them watching it on a screen, which is great. The fellow who ran the entire hospital at that time, Samraj, was an orthodontist who was an amazing administrator, and he had everything organized and running like clockwork. It was just beautiful to work with this man and with all the people that we had contact with. They were absolutely amazing. Typical story, ankylosis, no growth. How do you do your post-op care? You have to force the mouth open. Well, some enterprising person in the dental clinic made this corkscrew affair so he could screw it between his teeth, and as he turned it, it would go in, and it's getting wider and wider, fatter and fatter, so it's pushing the jaw apart, so he could do his physical therapy. And that's what's necessary to maintain the opening after doing the resection of the block of bone. And this is what the block of bone looks like. Here's a CT of the joint, and here's the middle cranial fossa. Here's where the condyle should be. It's all flattened across, it's all gone, and it's all fused. It's just a block of bone right through here. So there was no mobility on the left side of this poor kid's jaw. And that's what we resected, as in the picture I showed you from Nepal, where that piece of bone was sitting next to the boy in the ankylosis case. It was the same thing. Afterwards, we had a real ICU with nurses and ICU doctors, so that even the more dangerous cases, like the big tumors and also the ankylosis cases, were watched carefully. We could get right on an airway problem right away, and that made it safe enough to do the surgery. And here we are making rounds with the local folks, and they were just absolutely the best people you could ever imagine. So here's one case just to show you what we were doing in terms of the osteotomies. We had a dental lab, so we had plaster, we had models we could make, we could do the mock-up surgery on the models, move the pieces where we want, wax them together, make a splint to help guide the jaws into the proper position at surgery. It was a little crude, but it was all doable. And here's this gal who's a cleft patient. Her maxilla is completely retruded compared to the mandible, and we're going to try to widen the maxilla and bring her forward a bit. So we got to a fully staffed OR. We have our anesthesiologist, their anesthesiologist, surgeons, supportive staff, circulating nurses. We have everything we really need. So we operate on her, bring her forward. You know, this was not a home run, as you might say, but we might got a double on this case. Using a baseball analogy, we got her advanced somewhat, widened the maxilla, but got rid of the gap that was here, which prevented any type of prosthetic reconstruction. We have an iliac crest bone graft in here. And this is the ilium and the closure. And here's her afterward. Here she is afterwards. And after doing the work and working really hard, these are different concept cases because these are all long cases. They all took 3 or 4 hours. Bone graft, taking the hip, moving the jaws, watching the patients. It takes 45 minutes to an hour to prep the patient before we even get started. So this was a case where we went there specifically to do a certain kind of surgery. So we didn't have to feel guilty about not doing the kids with clefts or a big tumor. That just wasn't on the agenda. And after this 2-week process, each weekend, we'd go to this place called Ideal Beach on the Bay of Bengal, where they had a really nice place where you could relax for a day or two and eat some lobsters and watch the sunset. It was really pretty cool. This is the beach in the little town where the people earn a living fishing. And I actually went out on a boat just like this, so the fishermen one day, and we just went out until I said, you know, I can't see land anymore. Let's just go back. And we did. It's pretty scary, actually. You know, this is a little raft, and you're on the Indian Ocean. You know, if a big wave comes up, you can capsize. This is pretty risky. Makes me have more respect now even than I did before for Thor Heyerdahl, the guy who wrote Kon-Tiki. He was a Norwegian explorer who demonstrated that the Polynesians could have reached South Africa in their balsa wood rafts 1,500 years ago by sailing such a raft based upon findings of what rafts looked like on stone carvings on Easter Island, and showed that they could have done it. And he actually did it. So he was much braver than me. I just went out and back. And there's this great place called Mahabalipuram right near there, where there are these amazing sandstone carvings that are, I believe they're 800 years old, and they're very intricate. And I don't know the meaning of all of the figures, but there are guidebooks that can tell you that. And obviously it had something to do with elephants as well. And these are very old, no preservation. Kids are climbing on them, but fortunately they're not destructive. The Indian people seem to have some respect for their natural inheritance, so to speak. Right nearby was Kanchipuram. We had a chance to learn something about the Hindu religion in this lovely temple and a most interesting place. And one of the most beautiful thoughts, sunrise on the Bay of Bengal. So like on Sunday morning, we have one more day to relax before going back to see what kind of interesting cases we have to do during the week, get the batteries recharged, and charge forward. So 33 years later, that's me when I went to Nepal in 1988, and here I am with less hair everywhere except around my chin, which is now, I have a beard again, but it's all white. And I'm still enthusiastic about doing this stuff. It's still absolutely a wonderful opportunity to give something back so that lots of people can benefit from what I have learned how to do. So, thank you very much for listening. And if you have any questions, I'll be happy to answer them. So thanks for the invitation to speak, and I hope that it was of some benefit to listen to me today. Thank you very much. Bye-bye.
Hello, sir. Louis, sir, can you hear me?
I can. Can you hear me?
Yeah, I can, sir.
Hi. Hello, everybody.
I was just witnessing a great service which was done to the humanity, and we really enjoyed a nostalgic journey down the memory lane. And thank you very much for letting us walk along with you. And I was just thinking about doctors, science, frontiers, and all. Thank you very much, sir, for your work, taking us through many countries, especially the third world countries. And maybe it taught us a lesson that we too can serve a bit more to the people who are in need. Maybe we should go into the society, search for people like this, and do something more to make ourselves as what? Doctors, more than a doctor. Thank you
I
very much.
completely agree. You have to work with the people on site, or nothing is going to really work well. So you have to have cooperation, and you have to have the will for both parties. And if you do, you can be quite successful. And just one minor correction on my little commentary there about Thor Heyerdahl. He didn't go to Africa. He went to South America when he demonstrated that the balsa wood rafts could cross the Pacific Ocean. But this is a lot of fun. It's a lot of hard work, and it's extremely rewarding. But I frankly think that all of us have an obligation to help all those other people in our daily work, as well as going abroad to do different things. And that interaction, the best interaction between the visitors and the local doctors and nurses and staff is wonderful, because you'll be amazed at how much you learn from each other. It's really quite spectacular. So I thank you very much for giving me the opportunity to participate in the symposium. It's very, very, very nice of you, and I hope they have had a very successful one.
Yes,
Thank you.
Yeah.
Thank you, Dr. Clayman. Thank you so much.
Yeah, you're welcome.
It's so wonderful. What an amazing lecture. What an amazing lecture. Wow, what an amazing life. And I remember how we met 25 years ago, I think, right? 23 years ago. If you remember, in Anaheim, and I had a poster, and you were the head of the dental chairman committee, and you were right in the middle of the commission. And I went to you and I said, please come and see my poster. And you said, I already did. Do you have plans for dinner tonight? And then you ask the lady who runs the Anaheim Laser Institute, you ask her to organize a round table with about 15 people at that round table, students, doctors, professors. That was the most amazing ever event, right? Remember?
I absolutely do. That was a great deal of fun. And the discussion went very quickly from medicine to music.
Yes, because we are both pianists. Of course, you are much better than me, but being a doctor and a pianist,
It
comes together. Comes together well.
I was getting some interference there. Can you hear me?
Yes, I can hear you, sir.
Oh, good. No, that was just great. You know, that's one of the funny things about all these international meetings. I always meet somebody interesting at any meeting. And sometimes you develop lifelong friendships from the most unexpected encounters. It's really quite wonderful. You should always have an open mind about the world. That's the main thing to learn from doing surgery in different places and going to different meetings and working outside of your home network, so to speak. I'll tell you one other story. Do we have a minute for about a 3-minute story?
Yeah,
Do
sure.
we have
Sir.
enough time?
Yeah, sure. Sir.
This is about Kathmandu. This is the most extraordinary thing that has happened to me in any of these visits. In 1988 in Nepal, I did a partial, I think it was a cleft lip repair on a kid who needed to still have his palate repaired, but we couldn't do it because you could only do so much. I was in Vellore in India. Quite a few years later, way over a decade later. And some youngster comes up to me, he finds me somehow at CMC. He says, I don't know if you remember me. And I look at him and I did. This is the kid I had operated on. You have an unbelievable what's going on where people can find out what's going on without using a telephone or the internet. He knew somehow that I was in India. He found me. We operated on him in Vellore, and then there were in Vellore. They have a good prosthodontic team, but this boy had to stay at a very low level domicile for about 2 months to heal before he could have the dental procedures done. And he did. He wound up being in Vellore for 3 months. He had a surgery done. He had an obturator done. He had everything finished. And how he found out that I was in Vellore when I had met him in India some decade or so in advance, before, absolutely incredible. I still don't know how he did it. It was amazing. That stuff happens.
Yeah, thank you very much, sir, for the good session we had. I like to call in Dr. Taha, sir, to give his comments.
Yeah, big salute to you, sir, Dr. Clayman, for the wonderful service you have done to the humanity. And of course, Dr. Dana, I thank you for introducing Dr. Clayman to us. And it's a wonderful time sparing with you and your experience, your life dedicated service to the humanity. Thank you so much for being with us and enlightening our students and the doctors all over in India. Thank you so much once again for the great lecture.
Very welcome.
Thank you so much. See you soon.
I hope. Bye-bye.
Thank you, sir. I'd like to extend my gratitude to Dr. Suraj Kumar and Dr. Nikhil and Kuren as well for moderating this session. Now we have come to the end of the first session. We'll be continuing
and for
with
Dr. Dana also.
Thank you, Dr. Dana, and thank you, Dr. Chairman. Dr. P.S. Taha. Now we have come to the end of the first session. We'll be continuing with the second session immediately. I request you all to please stay back in the auditorium. We already have our next speaker online, and we'll be continuing in 5 minutes. Thank you, sir.